got certified as a case manager. Then I got certified and became an activity director. After that, I became a certified assisted living manager, and for 17 years I ran Alzheimer's programs in facilities. So I've seen it all and done it all. So if you have questions, it's happened. I've been hugged, I've been kicked, I've been lugged on, I've been bitten. So I can help you with hopefully anything. A little about us. This is going to be kind of a basic dementia education. Now, I'm going to deviate from the slides, I believe, a little bit because we're going to have time for it. Since some of you work with the respite program and many of you may have someone at home that you love, I'm going to talk a little about the vision and hearing changes that go on with a person with dementia and how to work with them. Because a lot of what we do wrong is in our approach.
Do we need the slides?
Not yet.
So Alzheimer's Texas was actually formed in 1982. We had a charter then. We've always had a board of directors. We're not the association, we're Alzheimer's Texas. 100% of what we raise and what we do stays here in Texas, primarily Central Texas. We service, I believe, 23 counties now, but we'll do consultations with people anywhere, even out of state if they call. I have one that was in Minnesota and their aunt lived in Austin, so they called us and we did it. So, like I said, 100% of what we raise stays here. It's not wasted or spent, I should say, on administration. We have a small office, 3 full-time people, and then myself. I'm the education and consultation specialist. So I'm the one that travels around most. So we would love to eliminate Alzheimer's and dementia. I'd love to be out of a job. But we haven't, and we'll talk a little about that as well, the research that's going on. It's not on the slides, but we'll talk a little about it. So let's do a little basic education in dementia. The Mayo Clinic now says there are over 80 known dementias. Some doctors even think it could be infinite. There may be dementias that one person will have and no one else will have. These are the most common forms of dementia. So dementia is an umbrella term. It actually talks about a set of symptoms which are related to most of these conditions. Unfortunately, it's at the bottom, but Alzheimer's disease is the #1 cause of dementia. It accounts for 50 to 80%, so I usually say 70% of the cases. Alzheimer's disease, we actually divide it into 2 categories. We have normal onset, which is age-related, that's over the age of 65. Then we have an early onset, under the age of 65. We're seeing more and more diagnoses of early onset. That doesn't necessarily mean there's more cases, it just means we're better at diagnosing. But there have always been a lot of cases. Now, early onset may have more of a familial component. It may actually have more of a component of genetics. I can't remember if it's in these slides, but if it's genetic, it accounts for, I think, less than 4% is what we say. And the genetic form of Alzheimer's actually involves one gene, it's the APOE4 gene, the same gene that causes Down syndrome. So they think 100% of people with Down syndrome, if they reach the age of 50, they're going to have the plaques and tangles of Alzheimer's. It's going to present itself differently, not so much in memory loss, but it will present. Any questions on Alzheimer's disease? None?
So are people actually diagnosed with Alzheimer's, or
They
I've
are.
heard they don't know it's Alzheimer's until after?
We can't 100% diagnose it until an autopsy.
Yes.
But there are a series of tests that take 4 to 6 hours with a neurologist or a neuropsychologist. And those tests will give us an idea as to what type of dementia it is.
Okay.
They say in the 90 percentile range, somewhere in there. So we can tell pretty much, especially with family interviews and with the testing with the person. Now, Alzheimer's disease, just a little background about it, it was discovered in 1907 by Dr. Alois Alzheimer. And he was a psychiatrist in Austria. He ran a psychiatric hospital. There was a young woman, she was in her 50s, I think 54. Her name was Auguste. He thought, this doesn't look like any psychoses we've dealt with. She's losing her memory. Auguste is famous for having said, I've lost myself. So when you're dealing with people with Alzheimer's, you may see that within them. They're aware of what's going on, and there are times they may express that. I had a resident in one of my facilities that said, I'm no good anymore, just take me out back and shoot me. So what they were saying in that moment was, I've lost myself. So we need to listen for those clues and understand that that's the time that we need to be really empathetic with them. So Alzheimer's disease, everyone kind of clear on it a little bit? The plaques and tangles are what Dr. Albus Alzheimer discovered. The plaques are amyloid protein plaques that most of us have, well, we all have amyloid proteins. Most of us can break it up and send it out of the brain. Some people, it gets sticky and becomes plaques. The tangles refer to a tau protein, which actually causes the neurofibrillary breaks and tangles. So that affects the brain's ability to send signals. So number 2 is debatable. We used to say it was vascular dementia. Now we think it may be Lewy body dementia. Vascular dementia is anything that affects the blood flow and the oxygen flow to the brain. Most notably, stroke will cause vascular dementia, but high blood pressure and things like that can as well. But stroke, it's actually called multi-infarct dementia, and stroke can strike at any part of the brain, so it can affect the ability of the person. All are different. In fact, when I first started in this business, I had a trainer that said, if you know one person with dementia, you know one person with dementia. Because no two are going to have the same journey. So vascular dementia is fairly common. I had a mother that had vascular dementia. Not much. She began to show it. She had congestive heart failure, and she began to show a little bit of signs. Lewy body disease. Has anyone heard of Lewy body? Lewy body is interesting. It's probably the number 2 cause of dementia. It's actually misdiagnosed a great deal. It looks like Alzheimer's in the beginning. Then we begin to see some changes. It's Parkinsonian in nature, but it's not Parkinson's. The person may have freeze-ups in their gait. They may just get frozen in spot. Or when they're getting out of a chair, they may freeze. The thing with a person with Lewy body is they don't fall like you and I do. They don't crumple as they fall. They slam. Full body. They'll slam forward. They'll slam backwards. If they're getting out of a chair, typically they're going to go flat onto their face. It's a really hard fall, and a lot of injuries occur with Lewy body patients. I always want to say residents because that's what I had, but patients. So Lewy body is interesting. All dementias have a chance of hallucination, but Lewy body is hallmarked by hallucination, both visual and auditory hallucinations. They may see people that have passed and be looking at them and telling you they're right there. They'll see small animals, dogs and cats. I've seen people actually call the dog. Many of them will see children. If I start to see children, you need to help me because I don't like kids. So I'm going to need help. Now also a person with Lewy body, this is why it's important to do that battery of tests and get a good idea. A Lewy body person, often if a person with dementia ends up in the hospital and they begin to, quote, act out, they try to get out of bed, the hospital will often medicate them to keep them a little more under control. And they'll usually use an antipsychotic drug. Lewy body people will have an adverse reaction usually to that drug. Not 100%, but most will. So what should be calming them will have them bouncing off the walls. And it can be fatal. A person with Lewy bodies can't take an antipsychotic. It could actually kill them. So, but we need to watch out for those antipsychotics anyway, within facilities, within hospitals. We need to ask questions. We need to say, let me know if there are going to be any medication changes and tell me what the medications are. So that's Lewy body. Any questions on Lewy body? Yes.
Just Just because they're seeing people or, like you said, the hallucination, that doesn't really necessarily mean they have the Lewy body.
No,
That's the
but
only
it can
thing
certainly
she has
be
is
a,
she doesn't have anything.
it can certainly be a clue, and you don't have to have had the Parkinsonian symptoms. You may begin to have them a little later. But the hallucination, most neuropsychiatrists and neurologists look at the hallucination and think, this could be Lewy body. But it doesn't necessarily mean it's Lewy body. With any dementia, you can have hallucination. You can also have delirium that can be caused by medication interaction. Most seniors take 9 or more medications. It only takes 2 to interact. So we need to be aware of that. Also infections. We're going to get to those in just a little bit. Here we go, reversible causes of dementia. Depression. Depression looks like dementia, especially in an older adult. We need to take into consideration if they've had a major loss or a reason for depression. An environmental change, something like that can cause depression. And it can make dementia appear worse than it is. It can also appear as dementia. So someone who may have lost a spouse may be despondent, stay within their home, quit talking to people, quit going around people, all of which are signs of dementia. They may dwell on the past and talk about stories that happened with them earlier on. Looks like dementia. So we need someone to really take a look at that, and we need to be aware that depression can look like dementia. Adverse drug reactions. Like I said, a person with Lewy body is going to bounce off the wall. It doesn't have to be Lewy body. Anybody with dementia may have an adverse reaction to a drug. Metabolic changes. When they do the blood work early on when they're diagnosing dementia, they particularly check the thyroid first. Hormonal changes can really appear to be dementia. They may be treatable. Nutritional deficiencies, vitamin B12. If you're deficient B12, you're going to start having memory issues and start looking like dementia. Also, imbalance in the sodium level can cause that. So that's all included in the initial blood work so that we can check that. Enlargement of the fluid cavities of the brain or hydrocephalus can happen. Tumors, they may or may not be operable. Tumors can be reversible, but not all the time. Depends on where they are. Infections, you heard me mention infections. Urinary tract infection is our worst enemy. Urinary tract infections in a perfectly healthy person can make them start being delusional, make them look like something's really wrong. So anytime there are acute changes in a person's behavior, we need to actually check physiologically first and see if there's something like an infection taking place. Because it's going to cause acute changes. It's going to happen overnight or in a couple of days' time. Sleep disorders. There are some new studies that think apnea may be a cause of dementia, which scares me because I have apnea.
Steve,
Yes.
that's the thing you're talking about, the urinary tract infection. That's exactly what happened to my sister-in-law. She got a series of those things, and things went from good to very bad in not that long a
It
time.
can. Urinary tract infection can really cause someone to nosedive pretty quickly.
Steve, all of these symptoms that you're talking about, do people go in and out? I mean, are they normal 90% of the time and then 10% have these symptoms, or are the symptoms there all the
I'm
time?
glad you asked that. People with dementia are all over the place. And that's why I hate to stage people and say stage 1, stage 2. It's not fair. People can have very lucid moments where it looks like nothing's wrong. And when I'm going to get off script and talk about the visual and hearing changes with a person with dementia. And we'll talk a little about what happens with the hearing so that you understand what's going on with them and how their speech can be automatic speech and look like nothing's wrong. But yeah, they can come in and out. They may be able to do something one minute and not be able to the next. You may be able to get them up there fine with dressing themselves, and then you get to the dinner table and they can't hold a fork. So it's all over the place. So there's no real static place that people stay. And it's unfair to think that they do. We need to treasure those lucid moments.
Right. Steve, have you ever encountered someone whose dementia seems to have been caused after a head injury?
It can be. That usually causes frontotemporal lobe dementias.
Okay,
And TBI, or traumatic brain injury,
that's,
is one of the major components. However, we tend to think of it that way due to the NFL and the films and everything that have come out. Most frontotemporal dementias, the majority are organic in nature, so you don't have to have ever had anything happen to have frontotemporal. But and a head injury can actually exacerbate Alzheimer's. If you have had
So-
several falls and hit your head, you may begin to show the signs of Alzheimer's.
because my mother was one that fell and hit her head and didn't tell anybody. And 2 weeks later, she had to have brain surgery to relieve, because she had been bleeding in.
Cause of brain bleed.
And so they saved her life, but it was a week later when she started with all the weird memory loss and all the weird stuff that has just gotten
With a
worse.
head injury, you don't know for a while. It can take weeks or even a month
Yeah.
or so before they have any signs at all that anything's wrong.
Right, yeah.
You can have a slow brain bleed for a long time before it shows anything.
That's, because one doctor diagnosed her with traumatic onset dementia because she had the injury. So that's, and it's just gotten worse. So we do know, I mean, we're pretty sure she does have, Alzheimer's or dementia of some sort, but.
And
yeah.
it's not unusual to have multiple dementias.
Right.
You know, she may have something from the head injury and have Alzheimer's that has started
Sure.
showing on top of it.
Sure. Okay.
People with vascular and Lewy body will actually start to show, a lot of them will show the plaques and tangles of Alzheimer's. So it's not unusual to have 2 or more dementias.
Wow.
Yeah, more than 2 is really scary, but you can have just any number at one time.
Okay, thank you.
Sure. So dementia versus normal aging. Dementia refers to cognitive changes that are significant enough they affect our daily life. And normal aging, you may have some memory issues and things like that happen, but it doesn't interfere with your daily life. You're able to go on. Dementia versus mild cognitive impairment. We see a lot of people with a diagnosis of mild cognitive impairment. It may or may be a dementia in its own right, or it may be early Alzheimer's, and they just don't want to call it Alzheimer's. They just are more comfortable with the family saying that it's mild cognitive impairment. Or if it's a doctor you've had a relationship a long time, they just are being cautious about saying it. So dementia versus Alzheimer's. Alzheimer's is a neurological condition that is progressive. Most dementias are progressive. Alzheimer's will continue to get worse, and it can actually take a life. Alzheimer's will kill eventually. A person many times will succumb to some other thing before that, but there's a time if you reach all the way to the end with Alzheimer's, and I've seen very few people that really reach all the way to the end, but your brain doesn't know to tell your lungs to breathe, doesn't know to tell your heart to beat, so it'll stop after a little while. So dementia is a condition of cognitive impairment that is caused by Alzheimer's and other disorders. And we went through the most common disorders a little while ago. And I didn't really go through the frontotemporal dementias with that, but we did since. So Alzheimer's statistics, its most common form of dementia between 60 and 80% of the cases. So I usually say 70% just to be safe. 340,000 Texans have Alzheimer's and over 5 million Americans. That is probably very low. The CDC doesn't keep statistics on Alzheimer's because where would they get them? They couldn't get them necessarily from doctors. They certainly don't get them from families. People that live in rural areas, there's no way of reporting it. So this is a guess, and it's probably low. 1.3 million Texans provide care for a person with Alzheimer's. That's low too. It's talking about primary caregivers. It affects an entire family. You'll find entire families pitching in on the care. Sometimes you don't, but it affects an entire family. It's the 6th leading cause of death in our state. People over 65 are at greatest risk. This is kind of a alarming statistics. 1 in 9 people over the age of 65 have the plaques and tangles of Alzheimer's disease. Typical duration is 4 to 10 years, depending on when it's diagnosed. The longest I've heard of anyone going with Alzheimer's is 22 years. There are no disease-modifying treatments, and I believe I have a slide on the medications, but if not, I'm going to talk about them. Some risk factors for Alzheimer's can be controlled but can't be prevented. So, exercise, do as I say, not as I do, and diet. Sticking with a healthy diet, what's good for the brain is good for the, what's good for the heart is good for the brain. So, the most recommended diet is the Mediterranean diet. My water's right in front of the fan, so it's getting hot. So the estimated occurrence by age, I think I have a slide on medication, but after this we'll talk about it. So 85 plus year olds account for 37% of the cases. 75 to 84 year olds account for 44% of the cases. That's because the 85 plus, the mortality rate is higher. So it's going to show it more in the 75 to 84. 65 to 74 year olds only account for 15%, so it's getting better. The news is sounding better. 65 year olds and younger only account for 4%. So memory changes, they'll complain about or even joke about not remembering. Oh, I can't remember anything. I have that Alzheimer's disease, and they'll say Alzheimer's. Honey, you'll have to remind me, I just can't remember anything. I can't remember to get dressed in the morning. You know, they'll joke about it a lot. Being unable to recall names of people or places, I'm sorry, but that doesn't have to be an Alzheimer's trait.
Thank you.
I'm notorious for that. I meet so many people that walk up to me
Right.
and ask if I remember them and talk about their mother, and I have no idea who they're talking about. Frequently misplacing things and asking where items are kept. I would also include in that hiding things and accusing people of stealing them. That goes on too. Now, misplacing things, that can happen with a person with Alzheimer's. My mother was notorious for her phone would go dead, and it would be because she would have the remote hung up on the phone cradle because it was the same size. Finding things like the phone or keys in the freezer because while they're talking, they end up and go in there and they just lay it down. Things like that begin to happen. Repeating questions, stories, or phrases. Any of you that have dealt with somebody with dementia, you hear the same stories over and over. And it'll drive you crazy, but let them process through it. Don't say you've already told me that. Eventually, the stories may go away if you're an interested listener and you ask questions. Questions to ask somebody with Alzheimer's is who, what, where, when, and how. We don't ask why because that requires abstract thought. But if they're telling you the same story and they leave something out, you can say, now where did that happen? Or who was there? How did that happen? You know, and by doing that, allowing them and actually exploring it with them, the stories will begin to get lighter, if not quicker, and may go away. Not always, but they may.
Are the stories usually related to a time period like early in your life?
All the memories that a person with dementia will have will be old memories.
Okay.
With Alzheimer's disease in particular, the first part that's affected is the hippocampus, which is where short-term memory is formed and stored. So I can ask a person with Alzheimer's, what did you have for breakfast? And they're going to suddenly get really hungry and say, I didn't have breakfast. They didn't come get me. I'm hungry. What are we having for breakfast? And my answer to that is feed them again. You know, I don't think that it works to try and reason with them and say you've already eaten. But yeah, the short-term memory will be gone.
Okay.
But long-term memory, things that happened way in the past, and sometimes it's borrowed memories. Sometimes it's things that they saw on television or that their sister or brother had happened to them and they wish it had happened to them and they'll tell it like it's their own. So with empathy, we listen. Did that answer? Okay.
Thank you.
Problems performing familiar tasks, forgetting the soap when washing dishes, difficulty remembering the ingredients. I had a person that moved into one of my facilities that was a gourmet cook. And her son said, Mom made some cookies, and they were horrible. Think about it. Salt and sugar look exactly the same. And you can make salt cookies, and they're not good. I remember, it made me think of when we used to make that dough with salt to make things at Christmas. But uncharacteristic difficulty organizing trips or anything that they normally organize. Difficulty learning and retaining new information. That's when we're going to start seeing older memories really take over. They're not going, they can learn. People with dementia can learn, it just takes a little longer. Language problems, consistent difficulty finding the right word to express their thoughts, substituting descriptions. Teepa Snow, who I trained with, she's an Alzheimer's expert. She does this play acting where a person with normal aging, we're going to go to the chocolate store, I'm going to get caramel. You're going to get, that white flaky stuff they put in chocolate. What's that white flaky stuff that they put in chocolate? Coconut. That's a person with normal aging. A person with dementia is going to say, I'm going to get caramel, and you're going to get, oh darn, that brown hairy wooden ball thing. If you're old enough like I am, they used to sell whole coconuts in the produce department. So they're going to think of that. It's going to come back in memory. But yeah, you used to buy that right along with the whole sugar canes. Yeah. They don't do that anymore. But struggling to communicate without halting. You know, we all take, little pauses in our thought, but a person with dementia, if they take a pause, it may become the end of the subject. Retreat from social situations due to anxiety about public speaking. Not just public speaking, it's afraid that people will notice something's wrong. Pastor Cindy, you have people that quit coming to church. They don't want the people in their Sunday school class to notice. You have spouses that quit coming to church because they don't want to bring them and have them be embarrassed. So that's a real opportunity for you guys to reach those people because they're at home alone. Orientation problems, geographical disorientation. People with dementia get lost, sometimes within their own home, especially if it's a home that they haven't lived in that long. They may feel at home, but what they're looking for is the home they grew up in. So they go to the hallway looking for the bathroom, and they find a closet. Temporal disorientation, what we mean by that is being all over the place in time traveling. Talking about a faraway memory like it's just recent. Visuospatial problems, difficulty visually interpreting the relationship between two objects. I may see a chair and walk over to it and I recognize it's a chair. I turn around and I go to sit down and I sit on the arm and I fall off. So I have a problem with depth. I'm going to take a pause here because I'm going to talk about what happens visually and auditorily with people with dementia, because many of you work with either the respite or you have someone you love that has dementia. So I'm going to have to put this on a stand and maybe walk away from it. I feel like I'm at karaoke. I would have just lost the karaoke competition. should stay. Did I turn it off?
No.
Okay, what happens with a person with dementia, and I'm going to have to step away. When we're in our 20s, we see everything peripherally. It was wonderful back then. I know my fingers are wiggling, but I can't see them because I'm not in my 20s. Why they don't drive better, I don't know, but they can see everything. They're just too busy texting. In our 40s, our vision comes in a bit. It's more in front of us, but we still see peripherally. In our 70s, it's more in front of us. We may become more cautious when we're driving. We may start and then stop and then look again. That's okay. But it's more in front of us. You still see peripherally, just not well. So with early stage dementia, primarily Alzheimer's, and I'm going to ask some of you to try and do this if you're willing. It's more like a scuba mask. If you'll hold your hands like this, and imagine your world being that. And that's early stage. Mid stage, it's going to be binocular, more like this. That's when we begin to see 2 dimension and 3 dimension kind of interchange. Can I borrow somebody? Now you've got dementia. So if you'll stand there. Now, do binocular for me. If I'm somebody that loves you, or I'm a caregiver, but if I'm somebody that loves you and I come at you like this, how does that feel? It feels pretty invasive. As Texans, we tend to go in for the kill. We think everybody wants a hug. So it's not good to do that to mom early on. Now, late stage dementia, it's going to be monocular, which is more 2-dimensional. No, one eye doesn't go out. It's just that your world is tight. You'll have social vision and task vision. I can't have both. I have one or the other. So, the way to approach someone with dementia, because now you know what's going on with them visually, the way to approach them is start in public space. Public space is about 2 arm lengths out. We need to respect this, even with somebody we love. They have to have a moment to adjust and see that it's us. Because they may be time traveling and they don't recognize a guy that's 58. To them, little Stevie is, 12. So they don't recognize me. So I need to give them a moment to adjust. We're going to raise our hand, even if it's somebody we love, to the right side of our face. Are you left or right? Okay, well, I'll show you left too. But we're going to raise our hand up to get them to look at our face. Hi, Mom, it's me, Steve. No, you got to mention, put your hand up. Hi, Mom, it's me, Steve. Now, somebody I love, I'm going to reach up, palm up. Somebody I don't know, I'm going to reach like a handshake. If she reaches back, I have permission to go in. I'm going to slip my hand into this. I'm in front of you. I'm going to step a little to the side where you can still see me. You turn your head and see me. I'm not blocking you. Now, that's personal space. Intimate space will be here. If I need her to walk with me, most of us tend to put our hand on the waist. It's not a dance contest. That turns people towards us. Putting the hand on the scapula, the shoulder, giving the scapula, come with me. They're going to walk straight. Now you can use this when you're doing tasks as well. Got the hand like this. If she needs to get dressed, and she's got some ability, she just can't do it. I can button her, and she feels like she's buttoning herself, or I'm buttoning her. Now the way I'm going to get her to think that is to put flat pressure on her shoulder. That pulls the brain into thinking that you're doing it. So by doing this, her motor memory will kick in. She feels like she's doing it. If I'm assisting her with eating, I can scoop the food, I'm holding the fork, and she feels like she is. We go up with the hand until she opens her mouth and I'm pulling it. But what happens, like in nursing facilities in particular, they'll sit in front of you and they'll scoop the food up and put it in your hands. Now, what I just talked about with vision, how do you think that's going to go?
Not well.
It's going to be pretty frightening. So any of you think you can try that with someone you love and it may work? The reason why we step to the side, what happens is what I'm doing is firing off the amygdala. If I'm right in front of you, every human has three things happen: fright, fight, or flight. That's just part of our reaction when people come near us or anything comes near us. So, if I frighten you and I'm in front of you so I don't see a way out, what's left? That's where the resistance comes in. That's where you're going to get pushed, shoved, hit, and the other thing is going to be the way you hear me. The way you hear me, the left side of the brain and the right side of the brain both have hearing centers. Left side of the brain is going to go first. That's where formal language is formed. It's where comprehension is. It's where you understand what I'm saying and you can respond back. All of that's going to go. That's going to be the first thing to go. What's left will be the right side of the brain. Now, on the right side of the brain, we have a few treasures. On the right side of the brain, we have automatic speech, social chit-chat, what I was talking about, the lucid moments. I had a lady that I just moved her into memory care from assisted living. Her daughter came to me crying. I just had a talk with Mama and she understood everything about me. She asked about my husband by name. She asked about my daughter. She even knew the dog's name. We moved her in here too soon. And I said, well, we'll do a care plan meeting in a couple of weeks and we'll see how this goes. As soon as she left, and she was a daughter that came every day. When she left, there's a knock on my office door and it's the mother and she's leaning on my desk. Have you seen my daughter? She swore she wouldn't do this to me. She swore that she wouldn't put me away anywhere. Now, she put me in this place and I don't like this joint. And she put me in this place and I haven't seen her in months. I don't understand what went wrong with her. I told her and she told me that she would never put me away. And she did. And I never see, so it went on and on. What happened with the daughter was automatic speech. Very lucid in the moment. I can't form a short-term memory. On some level, I have the daughter in my mind. On some level, I know she was there, or I at least visualize her. So on some level, I go and I get upset because my daughter hadn't been there. Did I see a hand up? So, did you have a question? Oh, okay, I thought you had a question. So anyway, that's what happens when somebody has automatic speech. The reason why I like to talk about automatic speech is if they can fool you, they can fool a doctor. A doctor gets to spend 15 to 20 minutes with the average Medicare patient.